Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight, we'll kick off with Dr. Blumenthal with Astellas Pharma, who will share a little info on their current trial. We will then hear from Dr. Amy Goldstein and Dr. Sunil Sharma from Children's Hospital of Philadelphia, who will give us a primer on mitochondrial disease. Simple overview of Mito, helpful info for the newly diagnosed, as well as those who just need a simple refresher, and great information to review prior to attending Mito Medicine 2022 in Phoenix. Our moderator this evening will be Margaret Moore, UMDF's Support and Education Associate. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors. So we ask that you join us in thanking the Edith Trees Charitable Trust, Zogenix, and Astellas Pharma for their ongoing support. UMDF Mitochondrial Medicine 2022 is right around the corner, and it is not too late to register. The next few slides will hit some highlights and things to consider before traveling to Phoenix. The upcoming Mitochondrial Medicine Symposium will take place at the JW Marriott Desert Ridge. Here is a quick glance of the meeting space. We are on the lower level of the hotel in Grand Sonoran Ballrooms, and from the bottom of the escalators, you need only glance to the left and you will see our registration area. This space is large, but we just want you to know that we are not the only conference in that meeting space that week. With that being said, it is a larger, beautiful space, but we cannot stress enough that we have a set of protocols to keep our attendees safe. You should have noted the waivers and agreements upon registering. You must be fully vaccinated, and masks will be required within our meeting space. There is a great travel checklist on our website. Scan here or visit umdf.org/symposium and click on things to consider before you travel to Phoenix. If you are unfamiliar with this year's program, visit umdf.org/mitofamily and check out the speakers and programs. A very popular part of our symposium is the Doctor's In, which gives attendees the chance to speak one-on-one with a Mito clinician. 3 hours on Friday and 2.5 hours on Saturday for signups. There are 15-minute slots, and we have at least 14 clinicians signed up to help us out during the time slots. If you are registered for MitoMed 2022, you will soon receive instructions on downloading the meeting app. We highly recommend that you do so. It will be a great tool on site to keep you informed about all the activities and sessions and learn a little bit about the speakers prior to the session starting. The tutorial will provide easy to follow steps. And make sure you have notifications turned on during the meeting so you can get the most current meeting updates. After the symposium, you will be able to watch most sessions on Mito University, but you can also tune in live on June 9th and June 11th for several sessions, including 2 Ask the Mito Doc panels. Visit www.umdf.org/mitofamzoom to register. Virtual sessions are free. Spring is here. Join us and walk your way this spring safely. Find a walk location near you and walk your way at Energy4Life Walk.org. Before we hear from our panel, we have some housekeeping items for you. We have muted the lines, so if during this webcast you have a question, please use the Q&A button to type in your question so that we can get answers for you. We ask that you keep your questions short for this webcast. We may not be able to answer questions that are too personal or detailed for this forum. Also, please note the information about the closed captioning at the bottom of your screen. Now let's get started, and Margaret Moore will introduce our first speaker.
Welcome everyone to our May installment of Ask the Mito Doc, What is Mitochondrial Disease? We're going to get started today, and I'd like to introduce Yukari Blumenthal, MD from Astellas Pharma.
Thank you for your introduction, Margaret. I'm Yukari and I work with Astellas. And today I'd like to share some information about our ongoing study. And this study is to evaluate safety, tolerability, and efficacy of ASP0367 in participants with primary mitochondrial myopathy. So before I start, just a bit of disclaimer. The information contained in this presentation is about study drug, which is not approved in any jurisdiction. So this is a continuous. Okay, so I don't know how many of you have heard of Astellas before, but our company's big goal is to turn innovative science into value for patients. This is just the background information about Astellas. We were founded in 1923, so we've been around for a while. And while headquarters is located in Tokyo, Japan, we have collaborators and offices throughout the world. And this is our study drug, ASP0367. It's a tablet form and you take once orally. And it's being investigated for the treatment of muscle weakness, fatigue, and exercise intolerance in patients with mitochondrial myopathies. So this drug belongs to a class of drugs called PPA delta modulators. And this class of drugs itself has been studied thoroughly in the past, but our study drug is a new addition to this class of drugs. And what we like to see is that with this medication, your body would start using fatty acid better, and your body would start generating energy more efficiently. And in turn, we hope to see that you experience improved muscle health and function. For example, you might feel less fatigued, and you might notice you have improved exercise endurance and so forth. So a bit about our studies. We have 2 ongoing clinical studies, and one is for Duchenne muscular dystrophy, and the other one is the one I've been talking about for PMM. So this is a phase 2 to 3 study, and we hope to invite a total of 175 adult patients with PMM. And we have about 15 sites opened across the United States. So if you're interested in participating in a site near you, this is a link provided here, or you can simply scan this QR code if we have more information for you. So I'm just going to go ahead and skip over the next few slides. It's about the details of the study schedule. So you can find this information in the link provided. So let's talk about who can participate in this study. You have to be an adult, age 18 and up, and you have to have a diagnosis established with PMM, which is confirmed by genetic testing, and you have to be experiencing symptoms. And you have to be willing and can adhere to the study requirements, including 6 minutes walk test, and agreeable to the use of digital applications and video recordings. And unfortunately, we have a list of exclusion criteria here. And if you happen to meet one of these items, then unfortunately you won't be eligible to join the study. But more information can be found in the link. And so with that, I'll be closing my session. But if you're interested, please visit the link provided here, or simply scan QR code. Or you can reach out to us at any time at Astellas registration@astellas.com. We're happy to connect with you at any time. Please don't hesitate to reach out. Thank you for connecting with us today. Thank you.
Thank you so much, Dr. Blumenthal, for that information. If anyone wants these links later, please feel free to reach out to me, Margaret Moore at umdf.org, margaret.moore@umdf.org, and I can get you this information. Next, I want to introduce our speakers for the What is Mitochondrial Disease talk today. We will hear from Dr. Sonal Sharma and Dr. Amy Goldstein, and they both are with the Mitochondrial Medicine Frontier Program. Welcome, Dr. Sharma and Dr. Goldstein.
Good evening, everyone. Are you able to hear me well, Margaret?
Perfectly.
All right. We can advance the slideshow. Our talk today, we wanted to focus on really the basics of mitochondrial disease, how it impacts the patient and their families, finding some strategies and resources, and also the support that you need in dealing with this diagnosis. Next slide. I really want to emphasize that mitochondrial disease is an umbrella term. It's one name for multiple disorders. Each mitochondrial disease is unique. So while you might read about a certain mitochondrial disease on Google or any other internet search engine, it might not entirely apply to you. Even within a family with a similar or the same genetic mitochondrial disease, the impact of it on different organ systems or the extent of the impact on different organ systems can vary. So it's really important to understand that everything you read may not apply to you. Next slide. So what is genetic mitochondrial disease? It's really the hereditary genetic DNA-based conditions. These conditions affect how well the mitochondria work in our body. It's important to understand the way these are written. So for example, the Milas condition, that is the M3243A2G, the M tells us that this is in the mitochondrial DNA, the 3243 is the position where that change is. The A to G is the transition in the base pair. So instead where it should be an A, it's a G. And that affects how the protein that is signaled by this gene is produced. So that's kind of how the nomenclature works. Nuclear DNA changes are also marked in a similar fashion. So mitochondria are basically parts of our cells that produce energy. They produce the ATP molecules. And when they do not work well, then our cells do not have enough energy to function normally, especially in times of physiologic stress. This physiologic stress can be an illness. It can be a big procedure, a surgery for which you have to undergo anesthesia. So these are really the stressors that require our mitochondria to work at more than 100%. And when they are damaged or when they are not able to function well, that's when we see that symptomatic exacerbation. Next slide. Mitochondrial disease is actually more common than we think. The incidence is almost 1 in 4,300 people. It affects males and females equally, and it has been virtually reported everywhere. It's important to understand that mitochondrial DNA mutations are quite common. So almost 1 in every 200 people will carry it, but that does not necessarily mean that that mutation is pathogenic or disease causing. Next slide. Now, in terms of symptoms of mitochondrial disease, this little diagram kind of highlights how there are multiple organ systems involved. A lot of the organ systems that do show problems or that do present with problems are the ones that require the mitochondria to work well, that require a lot of energy. So the heart, the brain, the gut, muscles, eyes, ears are some of the more common malfunctioning organ systems in mitochondrial disease. When they did a study to review clinical symptoms reported by mitochondrial disease patients, the average symptoms in a patient was about 16. Next slide. Neurological symptoms are quite common in patients with mitochondrial disease. This is why you see a lot of neurologists like myself and Dr. Goldstein caring for patients with mitochondrial disease. One of the important things is how well our brain functions. In children, we see this in terms of developmental delays, not reaching milestones, whether these could be motor milestones or cognitive milestones. Another thing we really look for and probe for when patients come into clinic is, are there signs of regression? Did they lose certain milestones when the patient went through an episode of acute illness? Cognitive decline in older patients in adulthood can be seen at an earlier age or a faster pace than you would expect for age. Another important and acute presentation is metabolic stroke. It's important to understand that this is different from adult stroke. It's not a blood clot that is preventing blood supply to that particular area of the brain. This is why the usual medications that are used for a stroke patient in the hospital are not useful in mitochondrial disease patients. We do have strategies in place to treat these metabolic strokes, but it's important to understand that the underlying cause in pathophysiology is different. Seizures and epilepsy is quite common. There's no specific epilepsy or a specific type of seizure that is particularly predominant in mitochondrial disease. There are some diseases like MRF where you might see more myoclonic seizures that would be rapid jerking movements of arms or legs. Movement disorders are quite common. We see a lot of patients present with dystonia, for example, which is a sustained painful muscle contraction. We tend to see this a lot with patients who have some injury to the basal ganglia on their brain MRI. A lot of our Lee disease patients will experience this. Recurrent headaches and migraines can be a common presenting symptom. A lot of our MELAS patients struggle with chronic migraines that can prove difficult to treat. Low body tone or hypotonia is important as well. Our body tone is really how our muscles react to passive resistance. And while with injury to certain areas of the brain, you can have increased tone, you can also present with low tone with certain genetic diseases and certain mitochondrial diseases. Muscle weakness, exercise intolerance is a big component, and fatigue is probably one of the most common presenting symptoms for patients with mitochondrial disease. Often we'll hear that before symptom onset, patients were able to walk a certain number of miles, run, bike, swim, and that ability progressively declines. Imbalance or ataxia is another common presentation. Ataxia could present in the form of recurrent falls, finding difficult, having a subjective sense of imbalance. Another important aspect to know is neuropathy that's really affecting our peripheral nerves. Neuropathy can present with tingling numbness type of feeling, usually in fingers and toes. Some people might interpret this tingling and numbness as pain. And another important thing to know is that while not every mitochondrial disease will have an abnormal brain MRI, there are certainly many diseases related to the primary mitochondrial spectrum where you will have specific abnormalities in the brain and the spinal cord. In fact, as mitochondrial specialists, one of our jobs is to delineate whether the abnormalities in the brain MRI or the spinal cord MRI could be explained by mitochondrial disease versus something else altogether. Next slide, please. Some of the other symptoms I wanted to highlight today were things to do with the movement of the eyes. So slow movement of the eyes or difficulty moving the eyes all the way to the right, to the left, up or down. This is ophthalmoplegia. Drooping of the eyelids, which you might notice more towards the end of the day. Changes in the retina, so retinopathy type of changes that is only evident on a full dilated eye exam through an ophthalmologist. Hearing loss, which is sensorineural, so it's affecting really how the brain interprets the auditory signal, not so much as conductive hearing loss, which is our ear's ability to really pick up that sound and transmit it. Hormone deficiencies are quite common. It's important to be plugged in with an endocrinologist who understands hormonal disease in mitochondrial disease. So for example, diabetes in mitochondrial disease has a different pathophysiology than the typical type 2 diabetes you would see in adults or the type 1 diabetes that you would see in children. Thyroid, parathyroid, adrenal glands are some of the other hormonal involvement we see with mitochondrial disease. The heart is a big organ that requires a lot of energy, which is why we tend to see cardiomyopathy, which is dilation or thickening of the heart muscle, as well as heart rhythm disturbances. This is why if you are diagnosed with a primary mitochondrial disease, your provider might ask you to see a cardiologist, even if you have no heart-related symptoms, because they want to try and track this or to identify it before it becomes problematic. Gut problems can be quite problematic. They can affect your lifestyle to a significant extent. The slow gut motility can present with bloating, constipation, abdominal pain, intolerance of feeds, vomiting. Sometimes people have to tackle this in children with G tubes or GJ tubes, become dependent on tube feeds or continuous slow feeds. So this can certainly be a big part of the problems that affect your life on a day-to-day basis. Poor weight gain and short stature are some of the constitutional things we see with mitochondrial disease as well. Next slide. Now, what causes mitochondrial disease? It's important to understand the genetic basis of these diseases. There are certain mutations which are pathogenic. Mutation is basically a change in the base pairs, which affects the protein the gene produces and therefore affects the function of the cell in our body. Pathogenic meaning that it is disease causing. We know that this change is problematic. We know that this change will lead to impaired function of the gene. These changes can be in the nuclear DNA, which sits in our nucleus. This is the DNA that we learn about in school. These are all the chromosomes where you get one copy from mom and one copy from dad. It's important to understand that the mitochondria have their own DNA. This is a small circular piece of DNA called the mitochondrial DNA. This is inherited exclusively from our moms. It's important to understand that there are thousands of copies of this mitochondrial DNA within the mitochondria, and that's where the concept of certain percentage of your mitochondria being affected comes from. Usually these changes are inherited, but they can also be new in a patient, and those are called de novo mutations. While we have learned a lot about mitochondrial disease in the last 5 to 10 years, there are many diseases out there for which we still do not have a genetic cause. And this is why we learn about them every day. Next slide. Mitochondrial disease mimickers are important to know. There are other genetic conditions, autoimmune conditions, rheumatological diseases that can mimic some of the symptoms of mitochondrial disease, whether that may be fatigue, whether that may be cardiomyopathy, whether that may be various neurological problems that are seen in mito disease. Some of these causes can lead to findings on labs. So on your blood, on your urine, on your muscle testing, it can show certain changes that tells you that the mitochondria is not healthy looking. And we call these secondary mitochondrial dysfunction, in the sense that there is a different primary disease process in the body that is affecting the health of your mitochondria, but it's not a primary mitochondrial disease. So for a definite diagnosis, you truly need to identify an underlying genetic cause. Just having certain findings in blood, urine, skin, buccal swabs, and muscle, while they can suggest how the mitochondria is working, does not help identify a specific mitochondrial disease. Next slide. So how do we diagnose it? We rely on, in addition to the clinical presentation, the physical exam, the imaging findings, we do a certain set of tests in blood and urine. These are mostly metabolic tests. They interpret how our body breaks down proteins, carbohydrates, fats. In these metabolic pathways, there can be certain errors which lead to a pattern of abnormalities that is recognized by the experts who interpret these tests, and they can indicate a specific type of metabolic error that can be seen with mitochondrial disease. It's important to understand that these will identify other inborn errors of metabolism as well that may not have anything to do with mitochondrial disease. If there is a high concern, then we will proceed with genetic testing. And this is testing your mitochondrial DNA, which can be done in different tissues, the saliva, blood, urine, as well as whole exome sequencing, which is really sequencing your entire nuclear DNA, the parts of it which code for proteins and looking for mutations that may be pathogenic. Sometimes we're not able to find an answer on the blood, urine labs, or genetic testing. In patients who we are very concerned about mitochondrial disease, we go ahead and proceed with muscle biopsy. This is an invasive procedure, but it allows us to look at the muscle tissue under the microscope, look at the health of the mitochondria in the muscle tissue, identify specific patterns that can be associated with mitochondrial disease. We can do functional testing on muscle tissue. We can look at how the different enzyme complexes within the mitochondria are working and be able to quantify whether somebody has complex 1, complex 2, or 3 deficiencies on muscle based on these tests. Most of the mitochondrial disease diagnoses, testing, and the process can be identified through guidelines, and the link to these guidelines will be provided in the chat. The Mitochondrial Care Network can help you identify an expert to deal with this process, to help with the process of diagnoses. Next slide. A lot of the times, you might question, why should you go through the process of finding a specific diagnosis within the mitochondrial disease spectrum? There are several reasons for this. One is that each mitochondrial disease is different, and knowing which specific type of disease you have will help understand what organ systems can be affected, what to watch out for, which specialists to be plugged in with. It can help you and your family better understand what to expect over time. We can look into other patients who've had that similar mitochondrial disease or were affected due to that same gene, and help you understand what to expect in terms of symptom evolution. Another important and really impactful reason for getting a genetic diagnosis is to be eligible for enrollment in clinical trials in future treatments for mitochondrial disease. These clinical trials do not enroll patients based on symptoms alone. They almost always need a genetically confirmed mitochondrial disease. Another very important factor is to learn the heritability, to be able to test family members to see if they might be affected, especially if parents carry the gene that might be causing the mitochondrial disease. It can equip them with knowledge to understand how to prevent that or how to plan future pregnancies. Next slide. So what do you do if you do not have a genetic diagnosis? Since mitochondrial disease is difficult to diagnose, being plugged in with the right specialist who has experience with patients with mitochondrial disease is really important, because oftentimes we will see patients that we're quite convinced have a mitochondrial disease, but we're not able to find a gene for it as such, and we're able to make that decision based on the overall presentation. In that case, we will do everything that we would do for a confirmed mitochondrial disease patients in terms of looking out for potential effects on your organ systems, getting you plugged in with the right specialists, having the right emergency plan for you. But for that, it's really important to go through the testing process and be plugged in with the right providers. Also important to understand that if genetic testing is non-diagnostic today, does not mean that you may not have an answer 2 years from now. We learn more information about genes and genes causing mitochondrial disease every day. When we reanalyze genetic information 2 years from now, that increases our diagnostic yield by approximately 10%. So it's important to have that information and to be able to undergo the reanalysis in an appropriate period of time, because often we will pick up on a causative gene that may not have been identified a few years ago. Next slide. It's important to label patients the right way so they can get the right care. Sometimes suspected or possible mitochondrial disease prevents patients from getting the actual diagnosis. It might lead to their treating physicians not caring for them in the similar way that they would care for the patients. An uncertain diagnosis together with a specific description of the symptoms seems to be a better way for patients to be treated, as when you do not have a confirmed genetic diagnosis, we don't want you to potentially not undergo the evaluation that you may need for a different diagnosis altogether. More information about this is also available online. Next slide. Now, in terms of what you do with this information, what about other children of a patient of the family whose child is affected by a mitochondrial disease, or future children? So depending on the type of the disease, other siblings or future children could be at risk. If a genetic diagnosis has been made, then you will get counseling through your medical provider and genetic counselor to understand which family members need testing, who has the ability to pass on this condition. And in case of future children, a genetic counselor can help you understand what are your options to practice in terms of preconception or prenatal testing, to be able to really empower yourself in understanding the risk of passing on the disease. Next slide. We are continuously learning about the impact of mitochondrial disease on caregivers. It's quite an overwhelming diagnosis to receive. It can be upsetting, it can be anxiety inducing. Having a diagnosis does allow you to stop focusing on the need for more testing and start focusing on treatment and how to help the patient. But it can really raise concern. It might raise concern for all the different health problems that you may not currently have, but you are at risk for once you receive the official diagnosis. This can be really stressful for everybody in the family. Next slide. You might feel burdened. You might not be very inclined to share your feelings about this. You might worry about the future, feel excess pressure. This might affect your household tasks, your ability to do your job. All of the doctor's appointments, the visits can really affect your ability to balance time between work and being able to provide for your child or your family member with mitochondrial disease. Next slide. So we do encourage, sorry, one slide prior. We do encourage our patients and their families to really take care of themselves and also understand the impact of this diagnosis on their mental health. Things that would necessitate or would warrant seeking professional counseling would be insomnia that is difficult to treat than usual, having negative thoughts, having thoughts about life not worth living, loss of appetite, short-temperedness, irritability, consuming more alcohol than normal, engaging in reckless behaviors. All of these can prove to be quite problematic if they're left undiagnosed, untreated, unaddressed. We are learning continuously about how much stress this can be for the caregiver and the families of our patients. And we want to highlight this and really empower our families to face these challenges more effectively. Next slide. I'm going to transition to Dr. Goldstein now so she can continue with the rest of the presentation.
Hey, thank you so much, Dr. Sharma. I was just typing the last answer in the Q&A box, so I'll turn that over to you while I am speaking, and then we'll see if there's extra questions at the end. So hi, everyone. Thank you so much for joining us tonight. This is a lot of information in a very short time period, but I think it helps to hear it again and again. As Dr. Sharma said, I will be carrying it on from here. And the first topic that we'll talk about is finding support. And I should mention this is with or without a diagnosis. So you don't have to have a genetic confirmation to get support, especially as you're undergoing this long diagnostic odyssey. And we know some of our patients have spent years trying to get to an ultimate diagnosis. So there are many support groups available. The UMDF is probably the oldest and the largest one that we have, especially in the United States, but it has an international reach. You're obviously all familiar with that because you're here. There's another organization called Mito Action, and from time to time we see partnerships between UMDF and Mito Action, especially when it comes to announcing clinical trials and things like that. But they also have some other programming that might interest you, so I would check them out. In addition to that, there are many other local, regional, international mitochondrial support groups. There's an IMP, the International Mito Patients Group, that was founded in Europe, that a lot of the Mito groups belong to try to really make sure that the support can be centralized and that people are really complementing each other when it comes to support groups. There are specific support groups for your particular issue if you have a diagnosis. So for example, there's PALS, People Against Lee Syndrome, which was started in Texas. There's Cure Mito, but also Cure ARS. And so there is a family of mitochondrial disorders called the MTARS genes. Those usually sound like DARS2, LARS2, ERS2. So there's now a foundation specific for those, that family of disorders. And so what's nice is that you can scope out and say, I want to belong to an organization that takes care of all of Mito. I'm missing one, and I know that Lissa is on this call because I saw in the participants, elhan.org. Welcome to all the Elhan patients that are here. And so again, you can have very specific support groups that really focus on your particular disease and really help keep the finger on the pulse of what's happening for this one specific problem, what are the clinical trials, and help you get very specific information. All of the support groups offer websites and staff that can provide additional information and guidance and resources, phone calls like this, sometimes local or regional support groups and programs like this where you can ask the doctor questions or provide other information. I did want to say just a little bit about joining support group forums. So I think it's wonderful. And I love nothing more when I hear, especially like a teenager say, I finally found another kid who's like me, right? So it's wonderful to join support groups and get this help. But I would also caution everyone that what works for one person, even with the same gene mutation, may not work for another person. So while you're sharing information, make sure that you run any advice that you've gotten on a forum past your doctor. I love it when people bring me new ideas. But again, you have to be cautious about what you read, especially when it's medications that should be avoided, which a lot of that is no longer true. So just caution when you're on the forums. Next slide, please, Kara. Thank you. So again, support groups are great. They can help you learn how to advocate for you or your loved one, find care, find services and resources, and share information about providers, right? I live in this area of the country. Who should I go see? I learned so much just from talking to my patients, and anytime someone sees a good physician that they liked, I write that name down so I can send my additional patients there. Again, we talked about this. Some advice you read may not be appropriate for you. So just caution when you're navigating these forums. Next slide, please, Kara. Okay, how about finding a provider? So a lot of people do not have access to a big center, right? You might live in an area of the country where there isn't a mitochondrial doctor, and flying to Philadelphia isn't an option for you. So what are you going to do? And so we really like to make sure that people have a good team. Having a good PCP is critical, especially somebody who can work with someone who has complex medical needs and working with complex specialists that might be involved, because you really want that person to be your quarterback and to help make sure that you're keeping track of, did I go to cardiology? Did I go get my hearing checked? Did I go to ophthalmology? What else is on the checklist that that you need to go through? And then if you need referrals, you need that person in your court as well. A lot of people also go see a geneticist, again, to help deal with genetic testing, having genetic counselors to help explain it to you, not only for the person who's affected, but also future children or other children or aunts and uncles and cousins. Neurologists, as Dr. Sharma said early on, we're both neurologists. I started seeing mitochondrial disease during my very early years in pediatrics, and I was very attracted to neurology because I saw how many people with mitochondrial disease have neurological problems. The brain and the nervous system take a lot of energy, so a lot of people will need neurologists to manage your seizures or headaches or neuropathy. And so again, neurologists are pretty critical. Just in case you have not heard about this, there is a mitochondrial care network that we formed in the US several years ago. This was a joint venture between the Mitochondrial Medicine Society and all of the patient advocacy groups at the time, which included Mito Action and the UMDF. And you can find a center if you go onto the mitonetwork.org. All of the centers, there's 26 sites in the US. They've all earned our stamp of approval. So we were quite discerning in who should be named a mitochondrial care network center. We made sure that there were pediatric providers and adult providers, or at least a way to transition someone to an adult provider. And we made sure that every needed specialist was available within that hospital system. So these are all academic pediatric hospitals affiliated with an academic adult hospital. And there is lots of information on the Mitochondrial Medicine Society. Several years ago, I spent Thanksgiving coming up with a map of providers all across the world, and it's probably a little outdated, but that map is still on the Mitochondrial Medicine Society webpage. And also the UMDF and Mito Action also keep a list of providers that can see patients with mitochondrial disease. Next slide, please. So how do you put together this team? So who you need depends on your specific symptom. And I have a lot of patients that get very overwhelmed because they might go to a doctor who says, you need to see everybody. Anything that ends in ologist, you need to go see. And what I recommend is that you really look at what your symptoms are, and that should be the priority of who you see. And then depending on what your particular genetic issue might be, we need to prioritize those systems that might need surveillance. So for example, in the first half of this talk, when Dr. Sharma was talking about cardiac issues, not everybody has a known cardiac issue, but some genetic mutations might have a very high risk of somebody developing an enlarged heart. You have to go every year to the cardiologist, whether you're having symptoms or not. So this is part of what your PCP and also your mito specialist should help you with, is prioritizing who and how often do I need to see anybody. How do you find? Again, coordinated care can be really helpful, especially if you're with a hospital that does complex scheduling. So if you live a few hours away from a hospital, it would be great to see the eye doctor at 9, the neurologist at 11, and the endocrinologist at 3, or something like that. And so you want to try to get all your care in the same day. And as I said, triage your symptoms so you can see who you need to based on the priority of your needs. And then where are you going to go? And so for some of my patients, they come from states away. And not everybody needs to see every specialist in my center. And so they may come to see me, but then I'll say, you know what, it's okay if you do this at home, go see the eye doctor at home, because they don't need to be a mito specialist. They just need to tell me what's on the back of your eye. And then I can help counsel them and work on that. So you don't necessarily need to shift all of your care to a mito center. Next slide, please, Kara. Again, I've talked about this in the last couple of slides. What are some of the more common specialists that you might need to help with evaluation and management? I've already talked about a geneticist or a metabolic physician, and there are some, this is kind of one field. Some people that do genetics also do metabolism, and some people just do genetics. What's the difference? If you tend to have metabolic issues, meaning you get sick and you have lactic acidosis, or you're on sodium bicarbonate to buffer that acidosis, or you get really hypoglycemic and it's more of a metabolic problem, it's better to have a metabolic geneticist involved in your care rather than somebody who doesn't have training in metabolism. I already mentioned the value of genetic counselors. We could not live without them. Neurology I mentioned, cardiology I mentioned, audiology and ENT. And so some of our patients have hearing loss, and they may need hearing aids and or cochlear implant at some point in time. So it's good to have that ear, nose, and throat team that can do that type of thing. Ophthalmologist, very important. The eye can really be affected in mitochondrial disease, as Dr. Sharma has told us, not only the back of the eye, retinal or optic nerve issues, but also the muscles that involve the eye. And I have some patients that see up to 3 or 4 different eye specialists. They have the oculoplastics to deal with the droopy eyelids, and then they have the retinal specialist to watch the pigment, and then they have a neuro-ophthalmologist to watch the nerve. They might have a glaucoma specialist. So you may need a lot of subspecialists even under one specialty area. A lot of our patients need a gastroenterologist. So the GI doctors can really help us out when there's slow transit through the gut, right? There's either gastric emptying problems, severe constipation. Some of our patients need tube feeding. Some of them need specialized medication. Some of them need specialized testing, right? They need manometry testing to see what's the problem. Is it the nerve or the muscle of the gut that's not moving? If I could have everybody see a nutritionist, I would love it, because I feel very strongly that what we eat, whether you have a mitochondrial disorder or not, is critical to our health. And I think that we don't always pay enough attention to this. So this is not only the kids that are really underweight. This is everybody. And we have to remember that the mitochondria are going to make energy from what you're feeding them. And so nutrition, making sure there's no deficiencies, this is critical. There's no special diet to be on. We still have no idea, and I think I'm going to come to that in the next couple of slides. We don't know if there's one particular diet, and I'll talk more about that when we get to that slide. Physical medicine and rehab is another specialty area that I think we're not taking enough advantage of yet. So physical medicine and rehab specialists are the doctors that really pay attention to tone, equipment, therapy, how often, how much, inpatient, outpatient, do we put on AFOs or do we not use AFOs? And so they really can help with those kind of issues. And they can also really help manage tone issues. So if somebody needs Botox or baclofen or other medications for tone management. Therapists, again, another critical piece for anybody who has developmental delays or physical issues that need help with either motor gross motor issues, fine motor issues, or speech. There's many more therapists that I could have listed here, but PTOT and speech are common ones. A lot of people also need vision therapy, or they do speech and swallowing together, or they go get balance therapy. So there's a lot of different therapists out there, and we know that there are issues with insurance not paying for ongoing therapy for many, many people. And so what our therapists recommend is you identify a problem. Let's say you're having trouble falling, and you go in and you say, I need 12 weeks of making sure that I don't fall, or I know how to catch myself, or what kind of equipment do I need? And you go get a little spurt of therapy, and then maybe you take a break and you make sure that they help you develop a home exercise program that's safe for you. And then you might go back 6 months later and do more. So we can talk about that a little bit more if that comes up. And then social worker. And some of the things that I'm going to talk about in the next couple of slides are going to really lean on our social workers for help. Okay, next slide, please. Thank you. So symptom management. So again, we want to make sure we can prevent problems if we can anticipate them and manage ongoing symptoms. Appropriate care should be available to everybody. None of us like hearing that somebody can't see a Mito specialist. So please check out the Mito Care Network if you can. And now with telemedicine, especially because of COVID did bring us that gift of having telemedicine more and more available for people, no matter what state you live in. We do very much focus on optimizing quality of life and being proactive and treating the treatable symptoms. And so some of my patients come in and they say, you know, my local team's given up, you know, and I'm like, why? There's still many things here that can be treated and that can improve the quality of life here. We don't give up, right? Staying active and as mobile as possible is incredibly important for mitochondrial health. You heard from Dr. Blumenthal at the beginning, right? There's a drug that is basically mimicking exercise. It's telling your mitochondria, we need more of you, grow, grow, grow. And exercise stimulates those same pathways. So if you can exercise, it is extremely important to stay mobile while also maintaining your safety. And so we don't want anyone just going out and starting an exercise program on your own, especially if you've had issues. If ideally you would meet with either a personal trainer or a physical therapist and have something designed for you, and then knowing where to stop. And that can also be really hard to determine. We don't want anyone in bed for 3 days because they overdid it one day. And as I mentioned, healthy nutrition is important. We don't have a specific diet to follow, but healthy and balanced diet is critical. Okay, next slide, please. Okay, so let's talk about some more symptom management and treatment. And I should say that this should be very individualized, right? There's no one Mito cocktail. There are papers that if you go onto the Mito Society, the Mito Medicine Society webpage, Mitosoc, MITOSOC.org, all of our papers are listed under education. And some of those papers you'll see are practice patterns in the United States. And what we did, this is when Dr. Parikh was the president of the MMS, he asked about 30 Mito doctors what they put in their Mito cocktail. He got 30 different answers. And so everybody uses a little of this and a little of that. What we've done at CHOP, there's a new paper that was written by Dr. Barcelos, Dr. Shadyac, Dr. Ganetsky, and Dr. Falk, re-looking at the Mito cocktail. It's important to keep in mind that there's still no scientific proof that anything is effective. And what that means is that there's no randomized, blinded, controlled trials using supplement and then no supplement and trying to compare those two groups. However, a lot of people say that they feel better on the supplements, or that what we're hoping is that we're prolonging or preventing more problems from showing up later. And we know that there are good reasons and rationale for using the supplements that we use. And at CHOP, one of the things that we benefit from is Dr. Falk and Dr. Wallace have labs across the street with animal models, and they try the supplements on the animal models. And that's how we find out what works. There's also a link there. More information about vitamins and supplements is available online through that link. That is not our paper. That's a different paper that was published by the Mitochondrial Medicine Society years ago. And we're about to rehash all of it all over again. New medications and therapies to slow down or stop the progression are being developed and currently undergoing research trials. And I don't want to underestimate the power of being in research trials. 10 years ago, this was still a dream that we would have clinical trials open for our mitochondrial patients. So it's very exciting that clinical trials are here. I love that the UMDF helps advertise clinical trials to the community, and you have the opportunity to meet someone like Dr. Blumenthal to talk about clinical trials. One thing to just remember is that clinical trials, any type of research, this is voluntary. And you really want to make sure that you or your loved one is clinical trial ready. What do I mean by that? You want to optimize everything. Make sure everything that can be managed is managed. So you're in tip-top shape when you go into that trial. And that includes nutrition, exercise, symptom management, etc. Okay, next slide, please. Thank you. So for prevention, we talked about all the surveillance, right? Eyes, ears, heart are the big three after the neuro system. And then labs periodically to monitor the endocrine system, the liver, and the kidneys. So even those labs are something that the PCP can do. This is like just a comprehensive metabolic profile looking at electrolytes, liver and kidney numbers. And then from time to time, especially based on whatever mitochondrial disorder you have, you might be at higher risk for something like diabetes or for endocrine issues or for adrenal issues or for thyroid issues. And again, eyes, ears, heart means going to the ophthalmologist, going to the audiologist, going to the cardiologist. There are guidelines for local physicians to assist in preventative care and management, available again at that link or on the mitosoc.org website. Other vitamins besides the Mito cocktail might be necessary. We have a lot of people that are vitamin D deficient, and we don't want it just normal, right? We want it, so normal, the range at your lab might start at 10. We want a vitamin D level of like 40 to 50 for proper muscle health. We want a vitamin B12 level of at least 400, right? So nobody should be deficient in these vitamins. You might need iron supplementation. We don't want anyone anemic. And as I said already, working with a nutritionist is highly recommended. There's no specific Mito diet. And I will just say that we do really pay attention, especially when epilepsy is a concern, about whether or not something like the ketogenic diet would be safe for a Mito patient. And that's a very individual decision that has to be made between your epilepsy specialist and your mitochondrial specialist. Next slide, please. Okay. As I said, there's no special diet. What we've been saying for years is to eat from the rainbow, try to eat a really healthy, colorful array, and to try to avoid inflammatory foods. So what are inflammatory foods? Anything that's white, right? White flour, white sugar. If you can try to do multi-grain or things that are colorful, it is much better for you. We are still learning what the role of inflammation has to the mitochondria. It's probably not good, right? So if you can eat from the rainbow, that's always better. Some patients might have, as we talked about the GI stuff, a very slow transit, and they might have gastroparesis, which means you feel Thanksgiving full all the time, even after only 2 bites. And so you might need smaller, more frequent meals. And so this is something that you can work with GI or with the nutritionist about. And some, not all, but some of our patients might need to avoid prolonged fasting. So some of our patients get very hypoglycemic. They might need to eat every couple of hours, right? And so there are nutrition strategies to deal with that issue. Next slide, please. Okay, there's a lot here, and I'll just kind of boil it down to this. Exercise, as I said, very important. However, we know that weakness, fatigue, and exercise intolerance, those are actually the top 3 symptoms of the survey. Dr. Sharma mentioned, we know that people have 16 or more symptoms with Mito. A survey that was done to prioritize what symptoms people wanted to fix during a clinical trial, those were the top 3. So it's very hard to tell somebody who doesn't feel well in terms of their energy levels to go start exercising. So it is very important when you start to do this with someone guiding you, making sure your form is good. You may want to go get clearance from your PCP to make sure that it's safe for you to exercise, especially if it's been a while. Some of my patients have not exercised in a long time and they need specific guidance when they get into therapy. And so sometimes I'll tell them to have the therapist use a Parkinson's-like therapy program or a post-cardiac surgery therapy program, right? So it's low and slow. And again, starting slow is very important. Starting with low weights is very important, but we do know that a combination of resistance training, meaning weight training, and aerobic training, something that gets your heart beat up a little bit, are both very beneficial. But how to do that, again, needs to be a one-on-one, very careful, individualized, and personalized program for you. I should also say that it's not good to exercise if you are having a fever or are sick. That's not a time when you want to expend more energy. And a lot of people really enjoy water, being in the water, aquatherapy, because that really takes gravity out of the equation and you can get a lot more range of motion and not worry about falling. So you can have some supervised aquatherapy as well. And this is for children as well as adults. Okay, next slide, please. Children might benefit from having some type of adaptive physical education class. A lot of my patients need me to write a letter saying, please let them self-regulate, because they might be able to do gym class if they're doing one activity, but not if they're doing another activity. And then there are a lot of other resources on exercise, and those links are there. And Nicole might be able to post those into the chat for you all. Some mitochondrial patients, we know they can go get something called cardiopulmonary exercise testing, or what we call CPET. And what we see on that test is that your heart, as long as you don't have a cardiac issue, your heart's working fine, your lungs are working fine, the oxygen gets to your muscle, and your mitochondria cannot get the oxygen into the mitochondria to use to make energy. And that's where the block is. More oxygen does not solve this problem. The oxygen's getting there. It's a problem of extracting it. And so this is what limits people from exercising, and it causes you to shift into not using oxygen to exercise, what we call anaerobic metabolism. And as soon as you're anaerobic, guess what happens? Your lactic acid shoots up and you get all that burning in your muscle. And this can be really tricky. We don't have a fix for this yet. But in case anyone was wondering why they can't tolerate exercise, this is why. You're trying to deliver the oxygen, it's not getting where it's needed. Next slide, please. Okay, so this is just more recommendations for exercise. Again, I've already mentioned we want strengthening as well as endurance. So some type of weightlifting, and this doesn't have to be heavy weights. This can be cans of soup, right? Doing some biceps, or making sure you're getting your arms up over your head, just even anti-gravity. Again, I want to encourage anybody who wants to do an exercise program to start with someone who can supervise you to make sure you're doing it safely. Okay, next slide, please. Thank you. All right. There's a lot of words on this slide as well. And this is what I want to tell everybody. There are still websites that have a very long list of medicines that say you should not take these if you have mitochondrial disease. And it's gotten to the point where people were afraid to take any medication. I actually had a patient come in today who had a sinus infection. He was told not to use Zithromax and to use a different antibiotic. And it boils down to this: the mitochondria descended from bacteria. So theoretically, any antibiotic should be toxic to the mitochondria. That's what happens in the dish. It's not what's happening in your body. And we've actually had more people get harmed by not taking an antibiotic because the infection becomes overwhelming than harm from the antibiotic themselves. So unless you have the mitochondrial DNA point mutation 1555, that means you can't take aminoglycosides, or it could cause hearing loss. Other than that, all antibiotics are okay. Now, that doesn't mean you don't have an individual response to that. So I'm saying that it is safe for you to take antibiotics, but if you're allergic to penicillin, I'm not saying go take penicillin. You need to see how your individual response is. If you feel terrible and you're sure it's the antibiotic and not the infection, then you need to look into that more. But there is certainly no long list of antibiotics that should not be used. The same is true for metformin. Even if you have MELAS or MID, right? A lot of my patients with 3243 A to G are on metformin for their diabetes. And maybe your lactate goes up a little bit, but if it's not overwhelmingly high, you're fine on metformin. It's okay. You shouldn't be taken off just because a new gene is discovered in you and you've been on metformin for 20 years to control your diabetes. Let's see, what are some other examples? Statins. So a lot of people are on statins for their high cholesterol. If you develop muscle cramping on a statin and it doesn't get better, maybe you shouldn't be on a statin. But just because you have a mitochondrial disease does not mean you can't take statins. So again, the list it could go on and on and on. There are volumes of books written on what medications could be potentially harmful to mitochondria. The one other big no-no is if you have POLG, polymerase gamma mutations, you cannot take Depakote. We already know Depakote will hurt your liver. That's it. But a lot of other mitochondrial disorders, if somebody has seizures or they need Depakote for another reason, Depakote can be used safely for many of the other mitochondrial disorders. And again, it really depends on which one you have. There are some other mito disorders, for example, PARS2, which is in that MTARS family I mentioned. And you really can't be on Depakote for that either, because it can cause an Alpers-like picture. So again, very individual, but I really want to make sure people are aware that there was a new project done several years ago. A new paper came out about reviewing drugs. This is also on the mitosoc.org website. And these are the only two contraindications, Depakote for POLG and no aminoglycosides if you have one 555 aminoglycoside associated deafness gene. Other than that, it's all individual and up to you and your doctor. And it's always a risk versus benefit ratio. But please do not decline antibiotics if you need them, because the infection could be much worse for your mitochondria than any potential side effects that are theoretical that you've read about. All right, next slide, please. All right, emergency care. So some of my patients do have an emergency room letter because they might go to the emergency room and you might look fine for the first hour you're sitting there, and then things quickly start to decompensate. And so an emergency room letter is really helpful to try to get you past triage into the back door. It's also helpful for us to emphasize from time to time that this is a kid who, let's say a child's vomiting, a lot of emergency rooms will say, well, here's a Pedialyte popsicle. And we're past that, right? Like, we need IV fluids now. That's why we're here. And so it does tell the ER what to do. It also alerts the ER that this is a patient that could decompensate quickly. Your patient could go into heart failure, liver failure, metabolic acidosis. Sometimes when we tell the ER this is what potentially could happen, it kind of triggers them to get you in the back. So sometimes we intentionally write some scary things that can happen in that letter. But the truth is that if there is something like an infection or dehydration or vomiting or something like that, your body's under more stress. There can be a decompensation. And so it really can be helpful to go to the ER if you are, you or your loved one is in that state. Again, the ER letters are available. There's a lot of templates available online. And so this is something that you can ask your doctor for. I also want to let you know at the bottom of the slide, you'll see CHOP now has an online resource. It's a clinical pathway that's used in our hospital now for the emergency room as well as during the admission. And it's a very long link, but you can even just Google CHOP clinical pathway and choose from the menu, and mitochondrial disease is there. And if any of you want to explore that further, it's accessible for anybody. But we're hoping that this is helpful, not just for CHOP, but for other hospitals all over the place. All right, next slide, please. Thank you. Surgery. So surgery can be another scary time. And I will say that when my patients come to me and say, I'm scheduled for this surgery, or I'm scheduled for the sedated procedure, I say, let's hold on. Let's make sure this is needed. And this is also why a lot of us really pause and consider deeply whether or not somebody needs a muscle biopsy, because that's surgery. And we don't want to, again, cause a stressor and make the disease worse while we're trying to make you better. And so surgery has its own special set of issues. So it's not just the anesthesia that you get, it's also the whole perioperative period. How long are they going to tell you to fast forward before you get there? What other things do you need to do? And then what about the recovery? And a lot of our Mito patients don't wake up when expected to after anesthesia, or you might have a lot of pain, or just sitting in the hospital for a couple of days, you might get really deconditioned really quickly. And so it depends on what surgery you're having and if there's blood loss, things like that. But for a lot of our patients, we do say, if the case is going to get delayed, if you have to have nothing to eat or drink for 8 hours or more, for them to hang a bag of fluid. And for some of our kids that are really fragile, we even admit them the night before, just so that we can kind of have them go to the OR with a full tank, as opposed to running on empty that next day. I will talk to our anesthesia team, and in some cases I talk to the surgical team. And sometimes it's convenient to get blood work during the procedure, but also monitored afterwards. And again, it really depends on what surgery is happening and how long the case is going to be. And we also have a whole separate anesthesia plan. So next slide, please. Okay, so now we're going to shift gears just a little bit more and talk about getting services. And so one of the questions is, how can you get services? And by this, we mean, like, there's a lot of emotional things that families need to deal with. If you're a mother that also has a mitochondrial mutation and you're learning for the first time, you pass that on to your child, this can create a lot of guilt. You might be angry, you might be confused, there might have been a delay in diagnosis. So there are a lot of really common feelings when you get this news, especially with a new diagnosis. And so it's important that you feel supported and that you know where to go get help. And again, there are many different resources, medical as well as financial, to help you get the help that you might need. Next slide, please. So one of the things that comes up all the time is health insurance, and we do encourage many of our patients, if they have a primary insurance, to try to get a secondary insurance to supplement their primary insurance plan. And it's really important to understand your plan and what will get covered and what won't. And a lot of insurance companies will have a case manager. And most of my families that have called and asked for a case manager get really lucky, and they have somebody who now understands your medical situation. And so when they see the requests come through for more medication, more services, more this, that case manager can say, aha, I know why this is being requested, and let me try to push this through so it gets approved. All right, next slide, please. Thank you. So disability insurance and Social Security, again, there are a lot of different ways to get on disability. And this is something that should be discussed with somebody who can walk you through this process. And so I know that Margaret at the UMDF has fielded some of these questions, but also we try to have our patients meet with a social worker, whether we're talking about a small child or a child that is turning 18 or turning 21. There's some legal things that parents also want to sort through around that time. And so you can request meeting with a social worker. And I think that could be a really powerful way to start sorting through some of this information. Next slide, please. All right, and then there's some other resources. So some people want to apply for the Family Medical Leave Act so that they can get some protected time off from their job to help, especially if there's a stressful or prolonged hospitalization, or they just need extra time to sort out care at home. There's a lot of early intervention programs, and I'm just so pleased to hear a lot of my patients that become adults, like they'll be able to stay in high school until they're 21, and then usually there's some type of adult programming that can happen if this is somebody that's not going to go to college or be able to maintain work afterwards. There's programming. And then there are legal services. As I mentioned, you want to think about things like guardianship and power of attorney. Next slide, please. There's financial assistance, and financial aid is not always based on your income. And there are places that you can request to help get medical expenses covered as well as living expenses covered. And again, usually the social workers are the ones that know about the pockets of assistance for you. Next slide, please. There can be travel grants. And so when we have people coming to see us from far away, we try to make sure that they know about travel grants, especially when there's a medical flight that might be involved. There are specialized flights that happen, miracle flights or angel flights. Many of the hospitals have some type of housing, subsidized housing, like Ronald McDonald House to stay in, and a lot of those places fill up. So it's always good to get tips from other families about how far in advance can you reserve a room and things like that. Some of the local hotels might also have deals for people that are coming in for medical appointments. So these are the kind of things, especially for your appointments, that you would like to check out. Next slide, please. There are also several grants for medical supplies, and I have a lot of them listed there. Mito Action has something called the Marcel's Way Family Fund, where you can get a one-time pocket of money that can help pay for some expenses. There's also GoodRx and compound pharmacies that can really lower your price of medications if you have a high pharmacy plan. Next slide, please. All right, clinical research, again, I emphasized this earlier, research is always voluntary, but so very important, right? We want to learn about these disorders. We want to learn the natural history. We would love you in a registry, either the registry, both the registry that the UMDF is running, which is down at the very bottom, Mito Share, but also different, there are different registries across the country. So we at CHOP have our own registry. We also participate in NAMDAC, the North American Mitochondrial Disease Consortium. And these are places where everybody can get counted. So if you have a really rare gene mutation and we look on the internet and we see, oh, it looks like there's only 8 other patients, well, that's what's in the publications. But how many people really have it that are walking around? We only know if you're in the registry and we can count you. So there's so many different ways to participate in research, either filling out surveys, being in a registry, and then the ultimate is being in some type of interventional clinical trial where you're able to get drug versus placebo. So these are really good, the websites that are here are really good ways to keep on top of what clinical trials might be available to you. And as Dr. Blumenthal said, there's always the inclusion criteria, right? Here's who we want. You need to have this, you need to be this many years old. And then there's exclusion criteria. And there may be some trials that you're not eligible for, but others that you might be a good candidate for. So just even if you get excluded from one, it doesn't mean you'll be excluded from them all. So these are really good things to keep on top of. The clinicaltrials.gov website, the Mitochondrial Care Network research webpage. NAMDEC has a web page that lists clinical trials. UMDF and Mito Action both list clinical trials. And again, you should be seeing email blasts from your support groups about clinical trials that are available. And of course, at the meeting, I'm sure we'll hear about updates for all of them. Okay, next slide. All right, I was hoping that we were getting to the end because I'm afraid that we ran a little bit over. If you're still here and with us, thank you so much for coming. I hope that this was helpful for you. Please give feedback to Kara, to Margaret, to Nicole. We want to make sure that these sessions are informative for you. And there will be other sessions at the upcoming mitochondrial meeting in June that will really help with newly diagnosed patients as well as deeper content. So again, thank you all. And hopefully we got all of your questions answered.
Thank you so much, Dr. Sharma and Dr. Goldstein. We have really enjoyed this talk today. I do have a few questions that were submitted prior to the meeting. And there's one's very specifically that I don't know that we touched on today that I think might be helpful to our patients and families. Stem cells and gene therapy, have there been any advancements?
That's a great question. And thank you for asking that. So for gene therapy, this is going to be a very complicated answer. I'm going to try to boil it down. For gene therapy, Elhan has had some success in some gene therapy trials. There was a paper recently published about the gene therapy trial for 11778. And the preliminary data are very promising. And from what I've heard, that may be going back into trials soon because it was not FDA approved quite yet. But like all things, we have to make sure that the gene therapy can continue to get produced and that trial will continue to happen. And I'm sure we'll get updates in a couple of weeks during the Elhan family meeting about the gene therapy trials. Gene therapy for other mitochondrial disorders is still being developed. And Cure Mito, which used to be Cure Surf 1, there was a lot of activity in Texas and Dr. Stephen Gray's lab about gene therapy. I haven't heard updates about that yet. And I do not know if there are any trials that are soon to be opening for mitochondrial disease involving gene therapy other than Elhan. As far as stem cell therapy, this is also a complex answer. Minovia, the corporation in Israel that was doing mitochondrial augmentation therapy, which is kind of like getting your mother's white cells infused for disorders like Pearson and Kearns-Sayre syndrome. That has been on hold since the pandemic, is my understanding. They had hoped to come to the US and choose a few sites. That's the closest to stem cell therapy that I am aware of. However, that doesn't mean that stem cell therapy is not available. And what I mean by that is I have several families that find out about a center either in the US or outside of the US that is offering stem cell therapies. And some of these places have never done stem cell therapy to a patient with mitochondrial disease. And those types of reports that I get from my families make me very anxious because I don't know if this is not a mitochondrial doctor, how do they know they're not going to harm my patient? And I get very leery over this. So I think this is such a difficult conversation to have because I know we all want a cure. We all are desperate for a cure for these disorders. And believe me when I say, I lose patients. I lose my patients. This disease can be fatal. I want nothing more than to find cures and answers. However, I don't believe in doing things that are not rational and are probably quite expensive for my families that go and participate in this. If stem cell therapy were going to work, we've had enough families that have gone that I would say, I would be able to tell you confidently whether I thought that worked or not. And we don't have any data that's showing that it's beneficial for our families. So sorry, Margaret, that was a really long answer, but I'm glad it was asked because again, I just want to be, I want to be hopeful, but I also want to be very protective of our families. And these are not trials that any of us are agreeing to at this point in time.
Thank you so much. I often see on social media people talking about that topic, so it's nice to address it directly. Another quick question: does melatonin help people with mitochondrial disease?
Dr. Sharma, do you want to answer that one?
Yeah, happy to do that. We often, that's kind of our first go-to thing to try when you are struggling with insomnia. It's important to understand that melatonin kind of reproduces or supplements what is a natural element being produced in your brain. It kind of gives your brain the signal that, oh, it's time to go to bed. And allows you to rest and go into sleep. So while it helps you fall asleep, it will not keep you, it will not help you stay asleep through the night. So some patients will tell us, hey, I took melatonin, I fall asleep, but then I wake up at like 4 a.m. So what we're looking for is for people who have difficulty falling asleep to get help with that. And it can be quite advantageous for a lot of people. You can always start at a smaller dose and increase it. Adults can take up to 9 to 10 milligrams of melatonin at night. Of course, it has to be coupled with good sleep hygiene. So you can't expect to fall asleep if you're looking at your phone screen and also taking melatonin 30 minutes before bedtime.
Thank you so much. Since we went a little bit over, I think it's probably a good idea for us to wrap things up, but I did want to remind everyone that's on tonight that Mitochondrial Medicine 2022 is right around the corner. It's not too late to sign up. There will be several virtual options, and you may have already seen some of information about that in the chat feature tonight, but please go to www.umdf.org/symposium and you can find those virtual sessions. I want to do a big, giant, and humongous thank you to Dr. Sharma and Dr. Goldstein for not only providing a presentation that I will use every day when I meet a new family. They will receive this wonderful gift, but also for answering so many questions in the Q&A while this presentation was happening. Again, thank you so much for joining us. We really appreciate all of it. And thank you to all of our guests that joined today.